Dr. Narayan is joining us today. She's with the Division of Endocrinology, Diabetes, and Metabolism. And Doctor, welcome to the show.
Thank you so much for having me.
A little bit about your background, how you got into medicine.
I got into medicine about 10 years ago. I started at Yale, where I went to medical school and did residency, and then did my fellowship at UCLA, and then joined Kaiser Permanente last August.
And how did you end up specializing in this area of medical practice?
Yeah, it's really interesting. You know, everyone in medical school says you pick the area where you're sort of most passionate about something. And we have a lot of diabetes in my family, so I initially had gotten into it due to that, and I love it. We get to see so many different types of people, different ages, different conditions.
Right.
And over my fellowship training, I started to become very interested in osteoporosis.
That's our topic today.
That is our topic.
Conveniently enough.
Conveniently enough.
I think a lot of people maybe think they know what it means or what it is. Maybe you can give us a definition of that.
Okay. I like to think of osteoporosis as basically a chronic progressive condition that leads to structural deterioration of bone. And I like to think of it as the fact that bone is constantly remodeling. So all of us every day, whatever age we are building bone and breaking down bone to make the new bone be more fresh. Osteoporosis results when the deterioration of the bone sort of supersedes the formation of bone. And the consequences are pretty devastating because as you lose bone mass, your bones start to look like this with lots of gaping holes in them. And the problem with that is over time this leads to the deterioration which may eventually lead to fractures. And the progression of the osteoporosis can cause fractures either knowingly or unknowingly.
You brought along the other one that you have there is, this would be not a bad situation. This would be the normal.
This would be what hopefully those of us in our younger age eventually build up. Most of us build up the amount of bone we're going to have by the age of 30. So everything after 30 is to hope to preserve this kind of bone.
Well, obviously most of our viewers, all of our viewers are over 30 and most of them are over 50. So we're looking at the other end of the spectrum and dealing with the potential for the holes, so to speak, as opposed to the solid bone there. So anything we do today is going to be trying to preserve what people have. And although I've seen at least one product advertised on television that at least claims to be able to regenerate bone, but we'll talk about that a little bit later. Obviously, the first symptom, I guess, would be a major break somewhere. Is there other symptoms of osteoporosis?
So that's actually the problem. Either fortunately or unfortunately, osteoporosis is asymptomatic. So people typically can't feel their bones weakening or feel this deterioration of their bones. And unfortunately, as you mentioned, people may not even know that they have osteoporosis until they actually fracture.
Right. So they really aren't, doesn't hurt unless you fall and break something, then it's definitely going to hurt.
And there's some fractures, specifically of the spine, that actually can cause pain. And if anyone has pain and shortening of their height, that is an indication to get checked out.
Okay. Breakage is the concept. Breaking bones, I guess, is how most people realize that they have it, unless they're getting tested, and we'll talk about that. But are there other consequences? Can it lead to premature death, possibly?
Yes, and that's actually why those of us involved in the osteoporosis community are really trying to make this effort to get people out there and get tested. The consequences are actually devastating. Approximately 1 out of 2 women who have osteoporosis and 1 out of 4 men with osteoporosis will suffer most likely a fracture in their remaining lifetime. Most of these fractures are of the hip, of the spine, of the wrist, and the number of fractures is expected to rise to more than 3 million by the year 2025. Anyone who has a hip fracture is at more risk for having a subsequent fracture, which is also devastating. And basically, for a woman, her risk of a hip fracture is equal to her combined risk of breast, uterine, and ovarian cancer. So it's a big risk, and we know in study after study that fractures due to osteoporosis lower quality of life. People just don't recover as well. It's been said that women, though they have fractures more often, men are more likely to die after their hip fractures. And it's just basically a destroyer of quality of life. And there are some studies that also say it reduces life itself.
We often think of this as a disease that primarily women deal with. You mentioned that men as well.
Absolutely.
So that means men should get tested periodically as well.
Absolutely. The years following menopause for a woman are the period of time where she's most likely to lose a large quantity of bone, and it's thought that female sex hormones, specifically estrogen, play a major part in helping build up and preserve bone. Similarly, for men, testosterone seems to be a major contributor, and so as men age, they tend to have lower levels of testosterone. So though the risk isn't quite as high as in women, there is a significant risk, and men typically over the age of 70 should be tested.
Okay. Hormone level testing then by the doctor should be part of a routine blood test probably.
For a man, definitely as he ages.
All right. Okay. We talked about the fact that unless you fall and break something, you're probably not going to realize you have this. But there are ways you can diagnose it and test for it. What's the test?
Absolutely.
How's the test involved?
So the test that we most commonly use at most centers is a bone density test called a DEXA. And what a DEXA is basically an X-ray, where it's a very quick test. You lay down in a machine, and it takes pictures of the spine and 2 parts of the hip, occasionally the wrist. And this machine is calibrated where the data is compared to age-matched, gender-matched, and in some cases race-matched controls, and basically gives a person an idea of what their bone mass is compared to someone of their own age. But the actual diagnosis of osteoporosis is made when these numbers are compared to someone who's in their 30s. So compared to someone who's achieved their peak bone mass. And from that, there are all these calculations with standard deviations that allow a physician and a patient to make a decision on whether or not they warrant treatment.
If somebody tests that they are having some loss, how often should they be retested?
So that's a really interesting question you ask. It's actually more complicated than a certain period of time. The most important thing is that when someone is retested, and usually the period is anywhere over 2 years, the test needs to be done at the exact same center where the first test was done, because these machines are calibrated in such a specific way that you need to have the old image to be able to compare the new image. So if you were to go to one facility and then have your follow-up at another facility, it's comparing apples and oranges.
I guess it means your technicians have to keep those machines working continuously for year after year after year to make that consistency in the testing as well. All right, so we've done the testing. We see that the person's bones look more like this than that one. Treatment. We see lots of things on television, including celebrities endorsing certain products. Some you take every day and you have to walk around and you can't eat breakfast. Some you take once a month. Some claim more less frequently than that. Obviously, we're not going to build more bone mass probably at 55, 65 years of age. We can certainly do things to eat healthy, exercise, and all of that. But what about some of these products we see advertised? Do they work? Do they help preserve bone? And can you build bone back up after 65?
Great questions. Just one word prior to that. When we get the bone density test, which is typically when we start treatment, there are new models that are coming out now that allow us to predict a person's absolute fracture risk, which takes into account not just the bone density, but certain other risk factors that a person may have to have a fracture. And so that helps guide treatment decisions a little bit better, because not everyone with just a low bone density needs to be treated. Treatment is something that's very important to be discussed with their provider. In terms of treatments, the global treatments that everyone should follow are calcium and vitamin D, and regardless of whether a person is being prescribed an anti-osteoporosis medicine, everyone should be taking at least 1,200 milligrams of calcium a day over the age of 50, and about 800 to 1,000 units of vitamin D. Vitamin D has been very popular in the press for the last 4 or 5 years. We're learning that there's so many benefits to it beyond just osteoporosis, immune function, muscle strength, so many things. Because ultimately, if you don't fall, then even though your bones are not good, you're not going to suffer a fracture, most likely. So calcium, vitamin D, exercise, as you mentioned, weight-bearing exercises, running, walking, climbing, all those things, not smoking, not drinking, and of course, not falling. In terms of the treatments, beyond that, based on a person's bone density as well as their other risk factors, there are basically 3 classes of treatment. You're right, there's multiple varieties and multiple brands of treatment within those groups, but